Welcome back, and now we're going to talk about the public side of healthcare financing. Now, of course, there are many different kinds of public health insurance and public health insurance programs, but what we know is that in 2013, 34% of Americans had public health insurance, and making up that 34% are about 17% that are on Medicaid, which is the state public health insurance program, and 15.6% who are on Medicare. And so we're going to talk a little bit about what some of these public health insurance programs are and how they're financed. But just to remind you, as we talked about in previous lectures, so we have the Medicare program, which is a federal program. We have the Medicaid program, which is based in the states. We have the Children's Health Insurance Program, which is designed to cover children whose parents are not eligible for Medicaid, to ensure that all children under the age of 19 have access to health insurance. We also have the Veterans Health Care Administration, as well as military health services for people while they're actively serving as well as after they have served, and the Indian Health Service, all supported by public funds, the taxes that you and I pay here in the United States. We've already talked a little bit about the Medicare program. As you know, it was created in Title 18 of the Social Security Act as part of Johnson's Great Society. The beneficiaries are primarily 83% of the beneficiaries of Medicare are age 65 and older. However, people who have disabilities or end-stage renal disease also are covered under the Medicare program. The Medicare program has 4 parts, and it's the same all across the United States. What we see is that the Medicare Part A, or the hospital insurance part of Medicare, is financed by our mandatory payroll taxes. And what you see here, highlighted in yellow, is our FICA, which is the Federal Income and Insurance Contribution Act, which was passed to require all people who are working to put a portion of their salary into this health insurance fund. There also is a separate line for the Medicare program, which also funds which also funds the Medicare program. So there are actually 2 lines in your taxes. The FICA goes to both the Social Security and the medical program, but the Medicare line specifically goes to fund Medicare and is mandatory as part of your condition of being employed in the United States. The employer and the employee equally contribute to that Medicare portion in the line, which goes into the hospital insurance trust fund. And right now it's 1.45% of your paycheck goes into that fund. When you become eligible for Medicare, you are not required to pay any premiums to access the health insurance, the hospital-based insurance, if you are a person or your spouse has worked 10 years or more in the United States. There is a credit-based system. You earn 1 credit per quarter of the year that you work, so you get 40 credits, or after 10 years, you have completely paid into the system and are guaranteed access to Medicare Part A. If you haven't worked close enough, let's say you've worked 9.5 years, you're short 2 credits, you can buy into Medicare to pay up so that you can get full access to Part A benefits. Part A benefits include inpatient hospital care. There is a lifetime reserve that you can draw on if you extend beyond your benefit period. Lifetime care of 190 days for psychiatric care. You can also have skilled nursing care and home health care covered through Medicare certified agencies. This also pays for hospice care. What we see in Medicare Part B is that this is a voluntary program paid in part by general tax revenue, but you also can pay a premium. This is where we see the private health insurance market getting involved and covering part of Medicare Part B. What we saw for Medicare Part B, what changed in 2007 as part of the Medicare Modernization Act of 2003, is that premiums for Part B coverage became means tested, or based on your income and that you had at the time when you're buying those premiums. And this helps cover for outpatient services, right? These are the things, they're not hospital, they're not inpatient, but ambulatory care services, outpatient services are covered by Medicare Part B. This is a supplemental Medicare insurance policy. Now, Medicare Part C, or the Medicare Advantage program, which became the Medicare Advantage program through the Medicare Modernization Act. It is a voluntary enrollment for managed care for both Parts A and B. Otherwise, you as the beneficiary remain on the Part A. It is a managed care program that allows for certain extra services to be covered. You have to pay an additional premium for this, but then you don't need to have your Medigap policy. Your Medigap policy, again, is that private sector policy that you are buying to provide for that coverage that isn't provided. So Medicare Advantage really reduced the need for Medigap plans to exist. So Part C, under the Affordable Care Act, what the Affordable Care Act tried to do was to reduce, actually, the amount of cost sharing for consumers buying Part C plans, because, of course, this is a group of consumers whose incomes are very limited or often certainly are fixed. These are people who are retired. And so for those folks who often do have complex medical conditions as they age, the idea was that cost sharing really isn't the way to deal with the fact that these people have regular health needs that they need to address. And so creating a system in which there is a disincentive for people to go to the doctor didn't seem to make a lot of sense. So they tried to cap the amount that you would have to pay in premium and to reduce the amount of cost sharing that people would have to pay if they're covered on the Medicare Part C. So again, the idea was to try to balance out the expenditures on this plan under the Affordable Care Act. And one of the concerns is that these Medicare Advantage plans had been being overpaid, that they were being paid too much for their services. And so the idea is to kind of cut back on those overall expenditures and to try to rein in some of those costs in those programs. Now we have Medicare Part D, the prescription drug plan. This was created in 2003 and rolled out in 2006. You can buy a standalone Medicare Part D plan, or if you buy a Medicare Part C Advantage plan, that you can have it so that the prescription drug benefits are included and they're all done through your managed care organization. This is, of course, voluntary. You do not have to have Medicare Part D coverage if you are participating in Medicare Part A. Premiums are subsidized and are means tested based on your income. So this is, again, a way to help seniors have access to prescription drugs. Now, what we see here is that one of the big issues that we talked about in previous lectures are the out-of-pocket costs for Medicare. There are no limits on out-of-pocket expenditures in the original Medicare program, and the typical beneficiary spends about 20% of their income on cost sharing. So as we saw on previous slides, it was very much a concern when people at the lowest levels of income were spending 10% of their annual income on cost sharing and on premiums. So for this population in particular, there are great concerns about cost sharing because they have a limited ability to pay. Nearly half of all of the Medicaid Advantage plans do have sort of a cap on out-of-pocket costs on the amount of cost sharing that's required. But as we talked about before, there is this considerable donut hole, specifically for Medicare Part D. And so what the Affordable Care Act is trying to do is to try to close that donut hole and to provide more subsidies so that consumers will be able to purchase their medications regularly, which we know will result in better health outcomes. So one of the issues is, of course, that there are significant out-of-pocket costs for consumers who participate in the Medicare Part C, Part D programs. And so finding ways to reduce those out-of-pocket costs, to actually reduce cost sharing in those populations, is one of the goals of the Affordable Care Act. What we see in terms of Medicare financing and spending, Medicare accounts for 1/5 of the nation's overall health expenditures. Now remember, this is just the population 65 and over, some disabled, and some people with end-stage renal disease. Now, that is a lot of healthcare expenditure for a relatively small portion of the population. Now, one of the concerns, particularly as the baby boomers are coming into eligibility for the Medicare program, there is concern that the Medicare Part A and Part B trust funds are going to go bankrupt. They've been running on a deficit since 2012, and the Medicare program is very much likely to be headed for insolvency unless there are some significant changes. The major issues are that there, of course, are rapidly rising healthcare costs of delivering care. We have a rapidly aging and ballooning aging population in the Medicare population. And what we also see is that the workforce that is currently working and paying into these Medicare trust funds is much smaller than the baby boomer generation that's about to need eligibility for these benefits. And so we see sort of this impending collapse of the Medicare program, which has raised significant concern. Now, what I want to show you is a little bit more in depth what we know about Medicare spending so that you have a more complete picture. Now, these slides all come from the Kaiser Family Foundation. Now, again, here, Medicare spending, 14% of the overall federal budget. We almost spend as much on Medicare as we spend on the national defense. Now, when you add Medicare and Medicaid together, we actually spend much more on our total health expenditures for public insurance than we do on national defense, and as much as we do for Social Security. So this is a huge amount of public expenditure to run the Medicare program. Now, what are we buying when we're buying health benefits in the Medicare program? Well, 1/4 of those expenditures are on hospital inpatient care. Now, another 1/4 are the expenses for the Medicare Advantage program. And then we have sort of all the other related services, physician patients for outpatient care, outpatient prescription drugs through Medicare Part D, post-acute care, hospital outpatient, and other services. So what we see in the other services category, we include things like hospital, medical equipment, Part B drugs, outpatient, et cetera, et cetera. So what we see is that hospital inpatient services are one of the big drivers of the increase in costs. So what we see in terms of the projections from where we are today, one thing that's really important to note is that back in 2010, we projected that the curve was going to be much steeper in terms of what we were going to spend per person. And so the Medicaid program, since the passage of the Affordable Care Act, has undergone significant reforms to try to reduce the amount of spending that is taking place. It's why we have the changes in the reimbursement system that we see for the Medicare program now, where we see these penalties and these incentives being put in place to prevent things like, for example, hospital readmissions. In 2010, the projection was that in 2014 we'd be spending about $12,300 per year per Medicare beneficiary, and that by 2019 that would increase by more than $2,000 per beneficiary. Now, remember, that projected increase was projected to be taking place at the same time when we have many, many more Medicare beneficiaries coming onto the rolls. So not only was there this steep curve, but also there was going to be this dramatic change in terms of the amount that we spend per coverage person. Now what we see is that the updated 2014 projection is that in fact we are spending much less per person today than we thought we would be back in 2010, and that in fact we see that while there still are increases, while the Medicare budget is going up, that the projected increase is much less steep. And so there is some hope that perhaps some of these reforms and some of these changes that have been made to the Medicare program are actually working. What we also see though, is that total Medicare spending is projected to grow much faster when we get to 2019 through 2023. That total expenditure is because of the rate of increase of the baby boomer generation coming to be eligible for the Medicare program. What we also see is that Medicare spending as a portion of the entire economy, as a percentage of gross domestic product, is also expected to significantly increase. But again, this is about sheer population, not about the spending per person. So overall, the outlook for the Medicare Hospital Trust Fund is looking better. However, we expect that the Medicare Trust Fund will be going to run out in 2030. The previous projections back in 2008, when these reforms initially were being proposed, it said we were going to run out of money in 2019. We were going to be, just in a few short years, not able to keep our Medicare program alive. Based on subsequent reforms and improved performance in the Medicare program, the projections have been steadily getting better and better. So there is hope to think that by the time many of us get to the age of needing the Medicare program, that it may still be around, particularly if many of these trends continue. Now, the Medicaid program. Now, this, as you know, is Title 19 of the Social Security Act. What we see is that how the Medicaid program is paid for is a mix of state and federal government funding, and who is eligible is based on their means or their level of income, and that varies, of course, from state to state. Under the Affordable Care Act, what we saw was that originally, when the Affordable Care Act was originally passed, all states in the United States were going to be required to expand their Medicaid programs. The Supreme Court ruled in 2012 that this was not constitutional, that it actually violated some of the constitutional powers that the states have to control how they operate state-based health programs. And so in the case of National Federation of Independent Businesses versus Sebelius, the Supreme Court struck down the mandate to the states on the basis that individual states should have the choice about how their Medicaid programs are run. So there would be no penalty from the federal government for not expanding, and that's how we ended up with 38 states that expanded and the remainder of the states not expanding their Medicaid program. So this left us again with quite a bit of uncertainty about the future of the Medicaid program. So on the old Medicaid program, for states who choose not to comply with the Affordable Care Act, there are automatic determinations for eligibility for welfare benefits, or TANF, for Social Security. Children and pregnant women whose income is below 130% of federal poverty level are automatically included in their program. Things like WIC are also included in this, and the medically needy as defined by the state. So there's sort of an automatic determination, either you meet the criteria or you don't. What we see also is increased attention to people that we call sort of the dual eligible beneficiaries. People who are, let's say, making lower than 138% of the federal poverty level and who also are disabled. They are what we call the dual eligibles. They are eligible for coverage under both Medicare and Medicaid. What this means is this group is particularly difficult to treat, particularly difficult to finance, and so there have been many different projects put in place to try to figure out what is the best way to deal with the fact that there are these people who are dual eligibles, how to manage their care, and how to cap the amount of expenditure that's being spent on this very difficult population. These are people who often have multiple comorbidities and chronic diseases, and so the effort is being made to figure out how to deal with dual eligible beneficiaries in the most appropriate way possible. What we see in terms of Medicaid enrollment and spending is that Medicaid plays a huge role for a number of really important populations. So if you look at Obviously, the non-elderly who are below 100% of the federal poverty level, 51% of those are enrolled in Medicaid. That means 49% of them who definitely are eligible for Medicaid coverage, even in non-expansion states, are not enrolled in Medicaid. So those are the populations that really would benefit from outreach and from getting onto the Medicaid program. The non-elderly between 100 and 199% of federal poverty level, 32% of those are covered, and that would either be in expansion or in non-expansion state, may be covered because of other things like disabilities or other eligibilities. Now for families, when we look at all children, of the entire population of children who could be covered by the Medicaid program, old and new, we see that 37% of children have Medicaid coverage. Of children below the 100% of the federal poverty level, we've done a much better job of reaching out to them through the CHIP program. We've done a somewhat better job of reaching out to parents who are below 100% of federal poverty level, getting them and their children included, and getting pregnant women of low income onto the Medicaid program have been about at the same rate. Elderly and people with disabilities, what we see as who also, again, these are these dual eligibles, about 20% of people are dual eligibles. We also see that there are other populations that are covered, including people who have HIV and people who are in nursing homes who are eligible for Medicaid coverage. So you see a wide range of variability among the populations that could be covered, those who are eligible for Medicaid, in terms of who is actually covered. The Children's Health Insurance Program, we talked a little bit about this in previous week. Now this is Title 21 of the Social Security Act. This is a set of federal block grants that again go to the states that allow for Medicaid to cover children who meet certain income thresholds. The federal government doesn't set the threshold, but state typically cover children up to age 19 in families with incomes of up to 200% of the federal poverty level. So this is where you see there's been much more success in getting children enrolled in the Medicaid program, less success getting families enrolled. Usually these premiums are highly subsidized. They're very cheap, could be $10 to $15 a month to have children enrolled in the Children's Health Insurance Program. So in terms of the cost to benefit ratio, families may often choose. You may wonder, well, why, if there are all these children who are eligible for the CHIP program, why aren't their families also signing up for Medicaid? Well, usually it's because in these populations of 100% of federal poverty level and below, or even up through 200%, the amount of the annual or monthly premium, they're very price sensitive to that. So getting coverage for children at a very, very small premium rate, parents are often willing to pay that expense, but they're not willing to pay the additional expense for them to be covered under the Medicaid insurance plan. You first have to try to enroll in Medicaid if you qualify. And so this is where we also see some barriers in terms of getting children enrolled, because the Medicaid enrollment process can be very complex and time consuming.